Chapter 33 Cardiovascular System Introduction. We will start with the anatomy and physiology of the heart. In this picture, you will see superior vena cava, inferior vena cava, and then the top part of the heart are the atrium. So we have a right atrium here, the left atrium here, the right ventricle. Ventricles are the lower parts of the heart, and then the left ventricle. And then we have the pulmonary artery that's coming from the right atrium, right ventricle here, going to the lungs. And then we have an aorta right here that is coming from the left ventricle of the heart. And then if you see that the heart is composed of muscles, and looking at this picture, you can easily see that the left ventricle has the thickest muscle, okay, layer. Now it's not in this picture, but it's also a picture in your book in page 596. If you want to take a look at that picture, you will see that on the right side of the heart, there is what we call the tricuspid valve. Okay, it's right here, but it's not, there's no name here. So tricuspid valve is right here, and then you will see that on the left side right here, that is the mitral or bicuspid valve. All right, so the functions of these parts of the heart. So the valve are kind of like the gatekeeper, so that once the blood flows from the atrium to the ventricles, or from the right ventricle to the artery, pulmonary artery, the blood goes in one direction and it doesn't go back. That's why there's a valve. It's kind of like stopping the backflow of the blood. But when we have problems with those valves, that's when we will hear those abnormal sounds, and then the conditions where the blood flow that is normally going on one direction will go back to where it came from. So just note that that's the function of the tricuspid, which is on the right side, and then the mitral valve, which is on the left side of the heart. Okay, now let's go back to the normal blood flow to the heart. Okay, again, we need to know what is not normal, so that if something wrong or something went wrong on one side or one part of that normal process, then we can understand why that's the signs and symptoms, and why is that the manifestation of whatever disorder. Okay, so for the normal blood flow, we will start with the superior vena cava that is collecting the blood from the upper part of the heart, and then the inferior vena cava are the ones that are collecting the unoxygenated blood from the lower part. Okay, so you have superior vena cava and inferior vena cava, and they are both meeting here in the right atrium. So now the blood flow comes from this two area going to the right atrium. From the right atrium, it's gonna go past the tricuspid valve, and it's gonna go to the right ventricle. From the right ventricle, the contraction will happen, the ventricle contraction will happen, and the blood will go to the left and right, left pulmonary artery to the left lung, and then the right pulmonary artery to the right lung. Okay, so the pulmonary artery. Then it's going to go to the lungs. Hold on. Lungs, right? Lungs. All right, now in the lungs, We did discuss in the previous chapter that this is where the gas exchange happens. So carbon dioxide goes out, oxygen comes in, and then the blood becomes oxygenated. From the lungs, it's going to go right here, right, right here, to the right and left pulmonary veins. Okay, that is going to meet here in the left atrium. From the left atrium, it's gonna go past the mitral valve, going to go to the left ventricle. From the left ventricle, it's going to go to the aorta, to the circulation or the body, right? Circulation. Now from the circulation, um, it's going to go to the cells in the body, and then it's going to go back to the inferior vena cava and then the superior vena cava. Okay, so that's the normal process of the blood flow from the heart to the lungs, from the lungs to the heart, to the circulation. All right, moving forward for the anatomy and physiology and some terminologies that we need to know. CO, or cardiac output, is the amount of blood that is ejected by the heart per minute. Okay, so let me write that down. Cardiac output is the amount of blood that is ejected by the heart each minute. This is in page 597 if you want to follow me from the book. The normal cardiac output that we want to see in a normal situation is between 4 to 8 liters per minute. Okay, 4 to 8 liters per minute. Okay, that is cardiac output, or the CO. Cardiac output is being affected by heart rate times the stroke volume. Okay, heart rate, again, the normal is 60 to 100, and then for the normal stroke volume is 60 to 100 ml. Right, so 60 to 100 ml for the stroke volume. Now, what is stroke volume? Stroke volume, or SV, is the amount of blood that is ejected each time there is a ventricular contraction. Okay, the amount of blood that is ejected each time there is a ventricular contraction. So we did talk about the anatomy and physiology of the heart from the previous slide, and I mentioned that the ventricles have to contract to push the blood from the ventricles to the circulation, or to the pulmonary arteries, right? So the stroke volume is the amount of blood that is being ejected whenever those ventricles contract. Okay, and again, the normal stroke volume is 60 to 100. Right. Coronary blood flow, left and right coronary arteries, we did talk about this a little bit, but in page 596 you will see a picture of those coronary arteries and veins. The one on the left side, which is the red color, that is the coronary arteries, and you can see the left coronary artery, or the LCA, and then the right coronary artery, or the RCA. Okay, so these are the ones that are helping with the blood flow of the heart. When we call an artery a collateral arteries, those are the arteries that connect those two, the LCA and then the RCA. Okay, again, it's in this picture right here, in page 596 if you want to see this. Okay, now conduction system. The heart will not contract if it's not triggered by an electrical impulse. Okay, so the heart needs that electrical impulse for it to contract. So in page 596, I also have a picture of this in a little bit, but just so you guys can visualize what I'm talking about. The conduction system starts in the SA node, and this is what we call the pacemaker, the normal pacemaker of the heart, because the SA node is the one that is initiating the electrical impulse. Okay, so SA node is the first one, that is the pacemaker of the heart, and that's the one that initiates the impulse. If in an event that the SA node does not work, there is a backup, which is the AV node, or the atrioventricular node. All right, so SA node goes to the AV node, and then after that, it will go to the right and left branches of AV bundle block, or the bundle of His we call it, and then goes to the Purkinje fibers. We'll go over that in a little bit, but just to touch base it right now. SA node is a pacemaker, and then the AV node is like a backup. However, the AV node, or the impulse in the AV node, is a little bit delayed. Okay, meaning that in the SA node it's going to fire from like 60 to 100, and then in the AV node it will fire like 40 to 60 beats per minute. Okay, all right. Then let's go over the S1 and the S2, which we will hear whenever we like talk about the heart, or we're listening to the heart sounds. We call it S1 and S2. So the S1 is the systole. We will hear it. This is the contraction of the ventricle. You will hear it lub, because the heart is like lub dub, lub dub. Okay. So S1 is the lub part. Let me write that down. S1, S2, right? Okay, so when we're listening to the heart, we will hear the S1, which is the contraction of the ventricles. So when the ventricles is trying to squeeze, okay, that's what we call systole. And then S2 is the relaxation of the ventricles when it's trying to relax after it tries to squeeze. It's called diastole, or S2. So you will hear, when you're listening to a heart sounds, you will hear S1 and S2. Lub, dub, lub, dub, lub, dub. Okay? All right. Cardiac function. Cardiac function, we have what we call preload, contractility, and then the afterload. So terminologies that we need to remember when we're talking about the heart. Preload is the amount of blood that is remaining in a ventricle at the end of the relaxation, or the diastole. Okay, preload is the amount of blood that is remaining in the ventricle at the end of the relaxation of the ventricle, or the diastole. Right? Contractility is the ability of the heart, the muscle fibers of the heart, to shorten and produce a muscle contraction. It's what we call contractility. Now, the afterload is the amount of pressure the ventricles must overcome to eject the blood volume. So when we are talking about um, afterload, this is not amount of blood, but this is the amount of pressure that the ventricles must overcome to eject the blood volume. Patients that have hypertension, this is where the problem is. Okay, this is the main issue with hypertension. I will write that down. Okay, that's why we call it hypertension, because there is a hyper or an extra effort to that tension, extra effort to that pressure in the ventricles for that blood to be ejected. Okay. All right. Vascular system. Resistance within the vascular system is controlled by the diameter of the vessels. So think of this as, so I will draw a lumen of the blood vessel. Right. And then the blood flows here, right? So like in a normal situation, the blood will be able to flow smoothly if the lumen or the opening is normal, right? Now, if I'm going to draw like a smaller vessel and then the lumen is very tiny, then you will think that the pressure in this vessel will be higher, right? Because there is a smaller passageway, there is a high resistance of the vascular system because of the smaller diameter of that vessel, right? So think of it, compare it as a water hose in the house. If you kind of like cover like part of the diameter of a hose, you will see that the pressure of the water that's coming out is stronger, right? Same exact concept. The smaller the diameter of the blood vessel is, the higher the pressure is. Okay, and obviously the bigger the diameter of the vessel, the lower the pressure is. Okay, another thing that can affect the blood flow to the heart is blood viscosity. So viscosity is the terminology that we use to describe how thick a liquid is. Okay, in this case we are talking about the blood. So if the blood is thicker, then it will be harder for it to flow to the circulation, right? And that's why um, patients that have these conditions, we will give them um, anticoagulants, is what we call it, those medications that are thinning the blood, and it's called a blood thinner because we want the viscosity of the blood to be thinner so that it will flow more smoothly in the circulation. Okay. All right, hypertension is above 140/90, and in order for us to diagnose a patient with hypertension, the blood pressure must be measured in like more than 2 occasions that the blood pressure is higher than 140/90. Also, we need to rule out things that could cause the high blood pressure, like let's say anxiety is one, pain, um, right? Patients that are anxious, patients that are in pain, their blood pressure will be higher. And so we want to rule out those things first to make sure that the reading is accurate. Okay, and accurate reading is important so that we can make sure that we are treating the condition properly. Okay, now we have the valves. So we did discuss the tricuspid, which is between the right atrium and the right ventricle, and we did discuss the mitral, which is in the left atrium and the left ventricle. Now we have more valves. Again, if you look at page 595, that picture of the heart, you will see that from the right side of the heart going to the pulmonary artery, that is a pulmonic valve. Okay, and then on the other side, from the left side of the heart going to the aorta, that little leaflets there is what we call the atrial valve. Okay, so in the heart, there's four. There's tricuspid, there's pulmonic, mitral, and atrial. Septum is what we call, or septa, is the one that separates the four chambers of the heart. Again, the four chambers of the heart is the right atrium, the right ventricles, the left atrium, and the left ventricles. Okay, then there are three layers of cardiac muscle tissue. There is the endocardium, the myocardium, and then the epicardium. Let's see, in the book, in page 595, it's showing you the myocardium. Myocardium is the muscle of the heart itself. Okay, the epicardium is the outer part. It's the outer layer of the cardiac muscle, the heart muscle. The myocardium is the muscle of the heart itself, and then the endocardium is the inside part, okay, of the cardiac muscle. Okay, looking at the book, the things that we need to highlight so far, in table 33.1 in page 597, the initiation of impulse, the SA node or the sinoatrial, the rate is 60 to 100 beats per minute. And then the atrioventricular or the AV node is 40 to 60 beats per minute. And then the ventricles are 15 to 40 beats per minute. Okay. And then in page 597 still, we talked about the cardiac output, stroke volume, and that the cardiac output is controlled or affected by the heart times the stroke volume. And the stroke volume is affected by the three things here, which is preload, contractility of the heart, and afterload. And then also the book gave you a definition of preload, contractility, and afterload in addition to what I just discussed. In 598, this is discussing the arteries and the capillaries. Okay. Okay. Now when we're going to listen to the heart sounds, the first landmark that we will look for is what we call the angle of Louis. Okay, and this is right here in the middle, and if you try to feel your chest, you will feel in the middle part that there's like something like a bone that is protruding in the middle, and that is the angle of Louis. Okay, right here. Now in the angle of Louis, this is by the second intercostal space. So intercostal space is one, first intercostal space, second intercostal, third, fourth, fifth intercostal space, right? So in the angle of Louis, if you go to the right side, you will see the aortic area or the base, or you will hear, I'm sorry, not see. You will hear the aortic area base in the second intercostal space when you move to the right side by the angle of Louis. And look at the picture right here. Where exactly are we listening to, right? Okay. Now, if you move to the left side, then you are listening to the pulmonic area of the heart. And again, this is still in the second intercostal space. If you move a little bit down, you are listening to the Erb's point. Then, if you go further down a little bit to the middle side, third intercostal, fourth intercostal, this is the tricuspid area. Okay, and again, we're listening to this side of the heart. All right, now the left ventricle is right here, and if you go to the mid-clavicular fifth intercostal space here, you are listening to the mitral area or the apex of the heart, which is the V shape of the heart, the U shape of the heart, and this is the PMI, right? Point of maximal impulse. Okay, so this is the apical heart rate or heart sound. Okay, and again, it's in the fifth intercostal space, mid-clavicular line. This is the clavicle, the bone, and then it's in the mid part. All right. Okay. So this is the picture in the book. This is in page 596, figure 33.4. And this one is talking about the conduction system of the heart. So again, we will start with the SA node, which is the pacemaker, and then it will go, or the impulse will go to the AV node or the atrioventricular node. And then from the AV node, it's gonna go down to the right and left branches of the AV bundle block, or we call it bundle of His. And then from there, it's going to travel to the Purkinje fibers. Okay, Purkinje fibers. So again, if the impulse is coming from the pacemaker of the heart, which is the SA node, the heart rate will be 60 to 100. Then, if it's coming from the atrioventricular node, like let's say something is wrong here in this area, and then the electrical impulse is coming from the AV node, then it will be at 40 to 60 beats per minute. Okay, a little bit lower. And if it goes down further, then the beats per minute will be lower, right? Okay. What else? Tricuspid valve, mitral valve, this is the atrial valve, and then somewhere here should be the pulmonic valve between this side of the heart to go into the pulmonary artery. Okay, let's talk about the age-related changes. So when we talk about age-related changes, these are those changes in the body as we grow older, and we will see this in the older population. And the goal of us discussing this is that so you would know what are those not normal but the common ones that we would see in an age-related changes. Okay, so for the heart, there will be an increased density of connective tissue and decreased elasticity. And what does it mean? Um, Remember that the heart is a muscle, right? And it needs to contract and it needs to relax. For it to contract and relax, it needs to be somehow um, elastic, right? In the age-related changes, the heart will have an increased density of connective tissue and decreased of those elasticity. So the elasticity, which is the relaxation and then the contraction of the muscle, will be decreased. Then there will be a number of pacemaker cells in the SA node will decrease, as does the number of nerve fibers in the ventricles. And we did just discuss the SA node and what is the function of the SA node. So if the number of pacemaker cells in the SA node is decreasing, then the number of or the beats per minute or the electrical impulse will be decreased as well. Blood vessel changes in the connective tissue and elastic fibers in arteries cause them to become stiffer. Again, the connective tissues and the arteries itself needs to be elastic for the blood to flow smoothly. If it's not elastic or it becomes a little bit stiffer, then the pressure will be high and the blood flow will be having more resistance. Veins will stretch and dilate, leading to venous stasis and sometimes impaired venous return. So, um, the function of the veins, let me see in the book. In page 599, you will see those two blue vessels in the right bottom of page 599. So those are veins, okay? And in the veins there is valves. Okay, the valves, again, the function is to make sure that the flow is going on one side, on one um, location. Okay, now if the valve is not working properly, just like in this left picture where the valve is open, you can just imagine that the blood flow will not go in one direction, right? It may just try to go to one direction and then it goes back down, right? And that's why we will see patients that will have like swelling in the lower extremities, for example, is because of those vein valves. Okay, those are failing. They're failing to close so that the blood flow actually goes to um, wrong direction. Okay, and then it will be an impaired venous return, impaired blood flow. That's why it's going to lead into that what we call venous stasis, where all of the fluids just stay in there instead of going into the normal circulation like how we discussed it in the beginning. Okay, nursing assessment. Common symptoms that we will see with cardiovascular disorders are the following: fatigue, edema, palpitations, dyspnea, and pain. And then the most common that we will see will be like hypertension, kidney disease, pulmonary disease, peripheral vascular disease, diabetes, stroke, rheumatic fever, streptococcal sore throat, anemia, smoking, and alcoholism. So those disorders here, they are the most common ones that we will see in patients that have problems with cardiovascular system. Also, we will ask for like family history of hypertension, um, coronary heart disease, CHD, and other cardiac disorders, because if they do have it in family history, they have a high risk of getting the same disorder. Same thing with peripheral vascular disease and the diabetes mellitus. When we do the review of system, um, weight gain is one of the biggest thing. The reason why is that the heart is pumping the blood flow, is pumping the blood, right? Then from the heart, it will go to the lungs. From the lungs, it will go back to the heart. From the heart, it will go to the circulation. That's the normal process. Now, if the heart is failing to do its job, you can just imagine where the blood is going to flow, right? If the heart is not squeezing properly or not doing what it's supposed to be doing, then the blood flow will go back to the circulation and it stays there, and therefore our patient will have some weight gain. Um, Same concept with the shortness of breath and the cough and the difficulty breathing is because of the same reason that the blood flow is not flowing properly. So that's why the patient may be retaining those fluids. Okay. Pain may radiate down either arm to the jaw or to just below the sternum. So the pain that our patients will feel is because there is not enough blood flow to an area. And when there's not enough blood flow to an area, then the patient will feel pain. Okay? Intermittent claudication. This is a chronic pain that is associated with decreased perfusion that is aggravated by exercise and relieved by rest. So here's what's happening here. The patient that have a problem with vascular um, diseases, so those blood flow that's supposed to be coming from the, let's say, the lower extremity of the body will go back to the heart, and then the heart will do its thing, the lungs will do its thing, and then it's going to circulate back to the other parts of the body, and then the lower extremity. um, there's a problem with that, so that what happens is that the blood flow will stay in there in the lower part, and most of them are now unoxygenated because it's not going back to the heart and it's not going to be oxygenated in the lungs. So that's why they will feel pain, because those blood flow that goes down is number one less, or number two is unoxygenated, it's not flowing properly. Okay, so we call it intermittent claudication because intermittent meaning it's not continuous. They will feel this pain whenever they are like walking, okay, or they are standing up, when because of the gravity. When the patient is resting, or you will ask the patient to sit down or maybe elevate the feet, then the pain, they will not feel the pain. Okay, so again, this intermittent claudication, this is aggravated by exercise, or walking too much, or when they are standing up too much. Okay, and again, will be relieved by rest. So you will ask your patient to sit down or elevate their feet. Rest pain, meaning that when you ask your patient to sit down and elevate their feet and just relax, they're still in pain. That means that there is a problem. There is a severe arterial occlusion. There is now an obstruction to the area. There is now a very bad blood flow. Okay, so we need to intervene right away because this is not a good thing, right? I mean, this intermittent claudication is not a good thing too, but this is worse. Right, vital signs. So when we take the vital signs, we want to make sure that we are, number one, using the correct size of the BP cuff, um, because if you use the wrong size of the BP cuff, then the measurement will be inaccurate. If it's too small, your blood pressure will be too high. If it's too loose or too big, then the blood pressure may be inaccurately low. Okay, So always pick the correct size of the BP cuff. Okay, then measure BP and pulse rates in the lying, sitting, and standing position. So we will have conditions that we call orthostatic hypotension. In the orthostatic hypotension, all right, let me write that down. So orthostatic hypotension. Okay, so in this condition, what happens is that when patient change their position suddenly, there's a drop in their blood pressure because the body is having so much trouble adjusting to the change in position. Okay, so in orthostatic hypotension, we will see patients that maybe is laying down for too long and then stood up right away or suddenly, and then their blood pressure will go drop right away. They may even faint. Okay, so for those people or patients, what we do is we measure their blood pressure and their heart rate while they're lying, and then you're going to ask the patient to sit, and then you check the blood pressure and the pulse rate, and then when they stand up, we will check again the BP and the pulse. So if there is a change of 20 millimeters of mercury or higher number of the change, then it will be an orthostatic hypotension. We usually will tell the patient or educate the patient to change your position slowly, okay, so that the body will have more time with the adjustment of the positioning. Right, palpating the pulses, and then heart sounds. We did talk about skin for color, hair distribution, and capillary refill, and palpate for temperature. Again, the skin, when we assess it, we want a warm skin, but not hot and not warmer, right? A warm skin, dry skin. We don't want a moist and wet skin. And then capillary refill should be less than 3 seconds, and then hair distribution should be normal hair distribution. All right, we talked about the heart sounds, and then there's what we call a heart murmur. Okay, heart murmur right here. This is a sound that is produced by turbulent blood flow across the valves. So I discussed the function of the valves, right? And you know what is the function of the valves now. So when those valves are failing to do their job and failing to close properly, that's when we will hear those abnormal sounds, and one of them is murmur. Okay, and murmur is the sound again that is produced by that turbulent blood flow across those valves. Right. Okay, and then we will hear or we may hear what we call rub, and a rub is heard when the pericardium is inflamed. Okay, pericardium, by the way, is the, so this is the heart, for example. Pericardium is what's covering the heart, right? Pericardium, right? Just like when we talk about the lungs, the pleura is the one that's covering the lungs. In here, the pericardium is the covering of the heart. Now, the pericardium can be, or there will be instances that that sac that covers or surrounds and protects the heart will be inflamed, maybe for infection. We will hear what we call a rub. Okay. All right. In the extremities, we're going to inspect the skin for color and then lesions. Which of the following is a pacemaker of the heart? SA node is the pacemaker of the heart. Okay. diagnostic testing and procedures. When the patient is complaining for like shortness of breath or chest pain, then we will start with checking their blood, their vital signs, and then including their pulse oximetry, right? Pulse oximeter. Pulse oximetry, this is non-invasive and this measures the oxygen saturation in the blood, right? So what we want to see again is like 95 to 100 if there's no chronic respiratory issues. Now we will do electrocardiogram or EKG or ECG, but we call it EKG. This is the study of the electrical activity through the heart muscle. Remember that the heart needs those electrical impulse, electrical activity for it to be able to contract and for it to be able to relax. So in the EKG, this is the checking of those electrical impulse. And the EKG is interpreted to detect abnormalities in the rate, the rhythm, or the impulse conduction. What we want to see in an EKG is a normal finding, and this is called a normal sinus rhythm right here. Normal sinus rhythm. And again, the EKG is detecting abnormalities in rate, rhythm, and impulse. So when we say that the patient has a normal sinus rhythm, that means that the EKG has a normal rate, which is like 60 to 100. The rhythm is regular, and then the impulse is also regular. Okay, and then in the EKG, you will see that PQR, PQRST that we will discuss in the next slide. But in a normal sinus rhythm, you will see that the PQRST are present. Okay, so those four things. PQRST is present, the rate is normal, between 60 to 100, the rhythm is normal, and there's an impulse conduction for us to see the normal, finding normal sinus rhythm. Okay, dysrhythmia is what we call when there is a disturbance of the rhythm of the heart. What we want to hear or see is a normal sinus rhythm, lub dub, lub dub, lub dub, with a rate of 60 to 100. When there is a problem with that, there's a disturbance of that rhythm. Let's say like a lub dub, lub dub, lub dub, lub dub, lub dub, lub dub, lub dub. Okay, then there is a disturbance of that normal rhythm of the heart. Then it's called a dysrhythmia. In the event that we cannot take the blood pressure of the patient in a normal way or a regular way with a BP cuff, there is another way for us to be checking their blood pressure. And it's more invasive because there will be an arterial line that is inserted, usually in the radial artery, and this is to provide a direct measurement of the systolic blood pressure and the diastolic blood pressure. Okay, but this is invasive. This is something that we will insert in the radial artery, and it's connected to that machine that is checking the systolic blood pressure and the diastolic blood pressure. Usually we will see this in like ICU patients or those patients that are really critical, that we have to monitor the blood pressure very closely and very accurately. Ambulatory EKG or a Holter monitor, we will have patients where they will complain of like, let's say, chest pain or any other cardio problems, signs and symptoms. And when we do the EKG or other diagnostic testing, they're normal. However, the patient is feeling the manifestations. So we want to kind of like dig deeper and kind of like monitor the patient closer. So what we do is we would give them a Holter monitor, and it's just like a little box, and it's connected to wires, and those wires are like connected to the patient like continuously, right? They will wear it for like, let's say, um, I don't know, maybe the order of the doctor would be wear it for 2 weeks, so that that Holter monitor is going to continuously check the EKG of the patient, and then hopefully we will be able to catch, what's the patient doing when there's an abnormal EKG. Okay. Right. So, but that's a Holter monitor. That's an ambulatory EKG machine, but it's very small, and it's like you can like hook it, eh, put it in the patient's pocket. Okay. Implantable loop recorder is, it looks like a pacemaker, but it's implanted. That's why it's called implantable loop recorder. And what it does is it's recording the EKG, or it's recording the heart activity of the patient in an X amount of time. So let's say the loop recorder is checking it for the 15 minutes, right? Every 15 minutes. So it's kind of like recording. Just in the event that the patient has like a cardio problem, um, that implantable loop recorder is connected, and then we can see and diagnose as to what was the patient doing when these manifestations are happening. Okay. Right. Echocardiogram is an ultrasound of the heart, and then there's also a transesophageal echocardiogram, which is not, it's more invasive than the echocardiogram, because an echocardiogram, it's just like an ultrasound. It's an ultrasound, so you will use that machine, put that chemical, and then you will put it by the heart area, and then you will be able to see the ultrasound of the heart. In the transesophageal echocardiogram, this is more invasive because it's going to go to the esophagus. Okay, so that machine, or like a tube, is going to go into the esophagus, and that's why it's called transesophageal, and then it's going to do that ultrasound echocardiogram from the inside of the esophagus, pointing towards the heart. Okay. And a stress test. So how do we do stress tests? So the goal of stress test is to see if the heart is actually able to withstand an exertion or the stress. All right. So what we would do is that first we would ask the patient to give the consent for us to do it, and then in the stress test, the patient will be connected um, in an EKG machine while they are doing some kind of exertion. So, for example, they will ask the patient to walk in a treadmill, or maybe run in a treadmill while they are connected to an EKG machine. And then that EKG machine is checking the heart activity while the patient is in a treadmill, running in a treadmill. Okay, so that is a stress test. All right, so this picture is in the book, I believe. It's in page 610. This is figure 33.11. Okay, this is the exact picture. So I will make this simple for you guys. So this is what we see in an EKG. Okay, we will see a P wave, Q, R, S, and then T wave, sometimes U. Okay, but what we will see normally, or what we want to see normally, is P, Q, R, S, and T wave. Okay, Now, each of them um, have a definition. Okay, so let's start with the P wave. Okay, the P wave is the contraction of the atrium. So remember the atrium, the right and left atrium of the heart, right? We have an atrium, we have a ventricle. So please go back to that knowledge, okay? So in the P wave, this is the contraction of the atrium, okay? Now in the QRS, this is the ventricular contraction. So why is the QRS too high, and why is the QRS more than the P wave? Because this is the contraction of the ventricles. Remember that the ventricles of the heart needs to work more, need to squeeze more, need to contract more for it to squeeze those blood flow to the circulation, right? Okay, so that's why the P wave here, that's a contraction of the atrium or atria, and then the QRS is the contraction of the ventricles. Now around this area too, but it's covered because the QRS is too strong and the ventricular contraction is too strong. Around this area too is where the atrial relaxation is happening. Okay, so ventricular contraction here and then atrial relaxation of the atrium. Now in the T wave, this is when the ventricles or ventricular that did the contraction is now repolarization or relaxing. Okay, repolarization means that it's relaxing. Okay, again, contraction, relaxing. So in here, the ventricles is now relaxing or repolarization. Okay, all right. So P is atrial contraction. QRS is when the atrial relax and then the ventricles will contract, and then the T wave is when the ventricles are relaxing. Okay, so in here too, when we are listening to the heart sound, remember that it's S1, S2, lub dub. So S1, you will hear it here, that's the lub, when the ventricles contract, lub, okay? And that's S1. And then when it relaxes, remember that that is S2, dub. That is the T wave or the ventricular repolarization, right? Lub, dub, S1, S2, right? In a normal situation, we're not supposed to hear S3 and S4, but there will be times or conditions where the heart is not doing what it's supposed to be doing, or the valves are not doing what they're supposed to be doing. That's when you will hear this S3 and then the S4, right? Which are just extra sounds of the heart. Okay, criteria for EKG interpretation. So when we interpret the EKG, we have to look at this criteria: rate, rhythm, P waves, PR interval, QRS complexes, ST segment, and then the T waves. For the rate, are the arterial and ventricular rates the same as measured by the P to P and R to R interval? For the rhythm, is the rate regular or irregular? The P wave, does it come before the QRS complex? Does each P wave have the same type, size and type? And then the PR interval is the distance between the P and the R. If you're looking at that slide, P and then the R, are they the same length, right? Because if they are on the same length, that means that they are a regular rhythm. If they are not on the same length, that means that there's some irregularity in the heart rhythm. QRS complex, excuse me, do the QRS complexes look alike? And then normal range is 0.6 to 0.10 seconds. I can show you that in the next slide. This QRS complex. ST segment, are they equal? Are they depressed or elevated? And then is the T wave number one present? And do they look alike, or are the T waves upright, which is supposed to be, or inverted, which is not supposed to be? Okay, for the QRS complex, this is a regular EKG strip. So you will see boxes here. We have like small boxes inside the box. So one box here is 0.2 seconds. Okay, so from here to here, that is 1 second. That's like 5.2 boxes. Okay, so that's 1 second. So if you look at this from here to this strip to the to the other line right here, that is a 3 second strips. Okay, so usually this is what we will see. Again, in here is a 1 second, 2 second, 3 second, and so on and so forth. All right, so in this box right here, it is 0.2 seconds. Okay, so when we did talk about, like in your book, page 611, it's talking about the P waves, PR interval, and then the QRS complex. It's asking you, does the QRS complex fall within the range of 0.06 to 0.12 second? Well, because we're talking about in here in one box, it's 0.2 seconds, 0.20 seconds. Okay. All right. Now, looking at this, so we did discuss that is the when we are talking about the rate, the heart rate, in table 33.4 and page 610, the first one there says rate. Are the atrial and ventricular rates the same as measured by the PNP and R to R intervals? So I'll give you an example. This is from P to P wave, right? P to P. So what you would do is you would see the distance between this P to the next P. Count those boxes. And then from this P to the next P, count the boxes. From this P to the next P, count the boxes. Are they the same number of boxes? If they are, then the rate is normal. Same thing with the R and R intervals that it's talking about. Where's the R? P, Q, R, right? That's a tip right here. So from this R to R, how many boxes are in there? What is the distance? From this R to this R, what is the distance? This R to this R, what is the distance? So if distance 1, distance 2, distance 3 is the same, then you have a regular rate, not regular heart rate. Okay, that is how we look for in an EKG. Okay, so in here, you could see that the distance here from the R to the R to the R here is equal. You could easily see it, right? If you count the boxes, you would confirm it, but you can easily see that the distance is actually equal. Now, the rate, you are going to count this in like a 60-second strip and like a 1 minute strip. And again, in a normal situation, it should be a 60 to 100 beats per minute. And this looks like a faster beat. So this will be maybe more than 100 beats per minute. But there is another way. In page 611 of your book, you read the rate calculations. Under rate calculation, it says most EKG strips have tick marks indicating a 3-second time. Well, this one's not one, but then 1, 2, and 3 seconds. Okay, so heart rate can be calculated from the EKG strip in several ways. The most common method that we do is to count the number of P waves or the R waves in a 6-second strip. Okay, so that means we can use this 1, 2, 3, 4, 5, 6. Okay, this is a 6-second strip. And you count the R waves right here. Okay, R wave are the tip of that wave right here, and then multiply it by 10, and that would be the bits per minute. Okay, so we have a 6-second strip here in the middle. Again, this 5 boxes here is 1 second, so it's 1, 2, 3, 4, 5, 6 second strip, right? And again, it says to calculate the rate, you are going to look at those R waves and then count them. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So I have 13, and it says I have to multiply it by 10, right? So 13 times 10, this 6-second strip here is actually 130 beats per minute, which means that the patient have a tachycardia. Okay. Let's see, 2, 3. Now let's practice right here on the top one. So we have a 1, 2, 3, 4, 5, 6-second strip, right? Now it says to calculate the heart rate, you're going to pick P or R, but let's stick with the R wave because it's easier to see. And you're going to count it in a 6-second strip. You have 1, 2, 3, and then 4. All right, so 4. It says I need to multiply it by 10. So the heart rate for this EKG strip is 40 beats per minute, and that means it's lower than the 60 to 100 that is our range, and it's called bradycardia. Okay. All right, this next one here, I just want to point this out. Let's see if it's in the book. This one is in the book too, the atrial fibrillation. It's in page 612, figure 33.16. So for atrial fibrillation, the ventricles or the heart itself is not pumping or squeezing properly. Okay, so it's not doing those relaxation, as you can see here. Like it will remember ventricle contraction, and then atrial contraction, and then ventricle contraction, and then relaxation, right? In here it's not happening. The heart itself is just wiggling. It's not relaxation. So this is how you will see an EKG for an atrial fibrillation patient. AFib is what we call it. Okay, also the rate will be high, and then you will see that the heart itself is not even able to like rest. Okay, diagnostic testing and procedures. So we will do like MRI, um, scanning, myocardial perfusion imaging, ultrafast CT scan, which are just a more advanced um, imaging too. And then we have what we call cardiac catheterization. Cardiac catheterization is when there is a catheter that is inserted into the vein or artery, and it's threaded into the heart chambers so that we can check what's going on in the coronary arteries. Um, in page 617, there is a picture that is showing you the right-sided and the left-sided heart catheterization. And also in page 16, it's talking about the cardiac catheterization, complications of cardiac catheterization, and how we actually do this procedure. Okay, so again, a catheter is inserted into the vein or artery, and it's threaded into the heart chambers and the coronary arteries so that we can check the if the blood flow is normal or if there's like an anomaly that we need to correct. Complications of cardiac catheterization, very important to remember as nurses. We will make sure that we are monitoring the patients for bleeding, because look at those catheter. Look at where it is inserted. In again in page 617, it's showing you it's in the femoral artery. Femoral artery is a big artery, and if this is punctured the wrong way, then bleeding can happen. Excessive bleeding can happen. That could be harmful and fatal to the patients. All right, so we are monitoring for bleeding, hematoma formation, infection too, because again, look at this picture and look, and you can see that the risk for infection is high. Embolus and thrombus formation, blood clots can happen with this kind of procedure. So we are monitoring them closely for bleeding, hematoma, infection, and embolus or thrombus formation. Laboratory testing. So we kind of talk about ABG testing with the Allen test testing when we did the respiratory system, but we are also doing this for the cardiovascular system assessment. And then we check for the creatinine kinase or the CK, troponin, which is another enzyme, and then the BNP or the B-type natriuretic peptide. Those are like enzymes that the heart is secreting when there is a failure. Okay, so that's why these BNP are high. You will see the level of this enzyme in the body, the B type natriuretic peptide BNP. You will see this high in heart failure because the damaged muscle keeps secreting it. Okay, so the CK2 and the troponin will be high. Again, they are enzymes that the muscles, the heart muscle in this situation is secreting when there is a failure or something is wrong. Okay. All right. So creatinine kinase or the CK, the normal that we will see in a male is 55 to 170, female is 30 to 135. And again, if it's high, then we are thinking that there's something wrong with the heart muscle. Troponin T and troponin I. So troponin is in a normal situation should be less than 0.1, and then the troponin I is less than 0.03. Again, if it's high, then that means that the heart muscle is struggling. Myoglobin is another enzyme that we check, and it should be below 90. Drug therapy. So in the book, from page 620, from page 620 to 627, it is talking about medications. A lot of these medications for cardiovascular disorders. They are divided into class. So the first page, 620, it's talking about digoxin, which is a cardiac glycosides. And then the second page is talking about the anti-anginal, and these are the medications. Next page in 622 is talking about antidysrhythmics, and those are the medications in the bottom. And then in 620, I'm looking for the antidysrhythmics or angiotensin inhibitors. In page 627, the vasodilators. Okay, that's the calcium channel blockers and the alpha adrenergic blockers. Okay, very important. So, but then take your time to read from 620, table 33.9, all the way up to 627. And these are talking about the medications. Okay, now let's go here. In the PowerPoint, cardiac glycoside is the first one, and again, the medication is the digoxin. So, the digoxin slows the heart rate and increase the force of the contraction. Okay, when this happens, it causes the increased stroke volume that we did talk about in the beginning and cardiac output. Okay, so for the digoxin, it slows the heart rate. We want to make sure we are assessing the apical pulse for 1 full minute. Okay, very, very, very important to remember for the digoxin is to assess the apical pulse for 1 full minute, and then we hold the drug and notify the healthcare provider if the heart rate is less than 60 beats per minute. Okay, another thing that we monitor for the digoxin is the potassium level of the patient. When the potassium level is too low, then it increases the risk of digoxin toxicity in the body. Okay, so that's why we're monitoring potassium level. Okay, anti-anginal. We use this to treat chest pain that's related to myocardial ischemia. So myocardial ischemia is when the blood flow to one area of the heart is blocked. So when the blood flow to the one area of the heart is blocked, then they will have what we call ischemia or death of the tissue, right? So when that happens, patient will have chest pain. And these medications that we can give is to help them kind of like dilate or open up those vessels that are blocked. Okay, nitroglycerin is the medication that we give, and this is sublingual, meaning we put it under the cheek, like under the under the by the cheek, under the tongue. Okay, so sublingual. And what we do is we will give this and then check if the chest pain is getting better. If not, you can give it again after 5 minutes for a total of only 3 doses. Okay, 3 doses. After the third dose, 5 minutes interval. If the chest pain is not relieved, that's the time to call 911. Okay. Now, we are going to assess the patient's blood pressure when we give nitroglycerin because it dilates, it opens up those, it tries to open up those blocked blood vessels. So when the blood vessel dilates, the blood pressure is affected. So that's why you or will go down. So want to make sure that the patient's blood pressure is actually not on the low side, because if you give nitroglycerin and then you dilate the blood vessel, then the blood pressure will bottom down. Okay, so we're assessing the blood pressure, assessing the pulse, and then we can give it 5 minutes interval, total of 3 doses. If the chest pain is not relieved, we call 911. Another thing to remember for nitroglycerin is that the drug decomposes on exposure to light and air. It means that this medication itself will come in a it's in a brown dark bottle. Okay, this medication decomposes on the exposure to light and air, so we want to make sure that they stay in that brown dark bottle. If it doesn't, if for any reason the drug is moved to like a bottle that is exposed, that can be exposed to light, then the drug can be decomposed and it's not going to work. Okay, all right, antidysrhythmics. Antidysrhythmics like amiodarone and diltiazem, this will help with slowing the rate of impulse conduction, depressing automaticity, and increasing resistance to premature stimulation. This is anti-dysrhythmia. We did talk about that dysrhythmia earlier on, when the rhythm of the heart is not normal. So we can use amiodarone and diltiazem, and this will help us with helping to normalize those, helping to get those dysrhythmia control to a normal rhythm. Okay. For diltiazem, we teach the patient to change position slowly because of that orthostatic hypotension that can occur, side effect of the medication. ACE inhibitors, or angiotensin converting enzyme inhibitors, again ACE inhibitor, ACE inhibitors. These are medications that work against the renin-angiotensin aldosterone system, the RAS system, and it dilates arteries and decreases the resistance to blood flow in the arteries, therefore decreasing the blood pressure of the patient. Okay, this one decrease heart rate. Vasodilators is a nitrocrucide. From the word itself, it dilates. That's why it's called vasodilator. It dilates the vessels, therefore decreases the preload, decreases the afterload, and will help decrease the BP of our patient. Right? Okay, more drugs. Diuretics. Most common one that we use is what we call furosemide or Lasix. And for furosemide and Lasix, this works with the this works by pulling those fluids that is being retained in the body, and then it works in the kidneys so that the kidneys can secrete more of the fluid in the body as a urine. Okay, now with furosemide we watch out for potassium, because with Lasix potassium goes out too with the urine. Okay, so that's why we're monitoring for potassium level, because we don't want the potassium level to be very low. And by the way, so now that we're talking about potassium, so potassium works in the muscles, right? With the muscle electricity of the muscle, but heart is a muscle. So that's why when there is a problem with potassium, the big thing that could be affected is the heart. Okay, so that's why we want to make sure that we are monitoring potassium when we are giving this kind of medication. Now, if the patient's potassium is low or on the low side, and we need to give diuretics to kind of like help with the retention of the fluid, Then we can give them what we call potassium sparing diuretics. One example is the spironolactone or the aldactone. And this one is helping to secrete fluid from the fluid retention. So patient will pee a lot. However, the potassium is being spared. That's why it's called potassium sparing diuretics. Potassium is not being wasted. However, we want to make sure that we are monitoring that the patient is not retaining a lot of potassium now, because now patient can have a hyperkalemia, which is also not a good thing. Too much potassium and too low potassium is harmful to the body, especially to the heart. Okay. Then we have anticoagulants. The rivaroxaban, Xarelto, apixaban is another name, Eliquis, warfarin, Coumadin. When we were talking about the blood viscosity, this is where it's actually helping, is that this medication are making the blood thinner. Okay, so but there is a risk. When we give these medications, we monitor the patient for bleeding. That means things like you're checking if the toothbrush that your patient is using is soft and it's not hard, okay, because their gums may bleed. Another thing is the like patients that are shaving. We want to make sure we're using an electric shaver, and it decreases the risk for like cut in their skin, because when there's a cut, of course it's going to bleed. And if the patient is on anticoagulants or a blood thinner, then the patient may be at risk for bleeding too much. Okay. Bruises too. Bruises in the body, that's a sign that there's like bleeding in the blood vessels, even though the skin is intact. So we are monitoring also for excessive bruises. Okay. Do not stop the medication suddenly without the direction of the healthcare provider. Then we have antiplatelet. Um, Aspirin is one that we use very commonly, and it works with the um, platelet. Okay, platelet is helping with um, when there is a bleeding in the body, and it's helping to kind of like stop it. Okay, but aspirin or an antiplatelet can help kind of like thin the blood, but not like a blood thinner. Okay, it's just helping a little bit with um, lessening those platelets that's circulating, and then making the blood a little bit smoother with the blood flow. Okay, but it doesn't work like an anticoagulant or a blood thinner. We are monitoring patients that are on aspirin too for bleeding too. Okay, Plavix is also another antiplatelet that we use, or clopidogrel is another name. So we are monitoring bleeding time, CBC, complete blood count, and the platelet count. Okay, again, report bleeding. Now we have fibrinolytics agent. This is more commonly used if the patient have a blood clot. Okay, fibrinolytic agents are those medications that we use to dissolve blood clots, right? Also, now that we're talking about blood clots, Homansign. Homansign, Homansign is a testing that we use to check if the patient have a DVT, or deep vein thrombosis. Deep vein thrombosis are those blood clots that is in the deep vein, usually behind the calf area. And when those happens, of course, that blood clot can travel and it can go to the lungs. That becomes a pulmonary embolism, or it can travel to the brain and it becomes a stroke. right? So that's why we are making sure that we are um, checking for DVT or a blood clot. And one diagnostic diagnostic testing that we do is a Homan sign. Okay, Holman sign is when you will ask the patient to lay down in a supine position, then the knee will be extended, leg will be extended, and then you will kind of like push the dorsal part of the foot up. And when they feel a pain in their calf, that means it's a positive Holman sign. There's an indication of a blood clot or a DVT. And again, we don't want patients to have these blood clots because it can travel to the heart, lungs, and brain. In this situation, it can travel to the heart, give the patient a myocardial ischemia, give the patient a heart attack, myocardial infarction. Okay, so that's why we will give them these medications to prevent a blood clot. Or fibrinolytic agents is one medication that we use to dissolve a blood clot. Okay, right. Lipid lowering agents. Why are we giving or making sure that we are controlling the cholesterol or the lipid um, of our patient? Is because those plaques, we call it plaques, fat plaques. Okay, they can build up in those blood vessels in the lumens, and then it can even block the blood flow to the area. And that's why we are giving them these medications like simvastatin, the statins, the lipid lowering agents, lovastatin, atorvastatin, and then there's also this medication cholestyramine that can help lower the lipid or the cholesterol. Common therapeutic measures for cardiac conditions: sodium restriction if the patient is especially retaining some fluid, because when the sodium in the body is high, then the body will retain more water, and when there is more water that is being retained in the body, the heart will work um, twice as much, right? You can just imagine the amount of blood that it needs to pump. So that's why patients that have, let's say, congestive heart failure, we want them to have a sodium restriction because we don't want them to be retaining more water um, or more retaining more fluid in the body. Potassium, I did explain it, especially for diuretics. Nitroglycerin, um, we did talk about this 3 times, 5 minutes apart. Also, in addition to the nitroglycerin, when we're dealing with patients that have a chest pain, we can give them oxygen, um, making sure that their body is still oxygenated, and then we can give them morphine for the pain. Kind of like helps also with um, lessening their respiratory rate to kind of like relax the body, right? CPR, cardiopulmonary resuscitation, is what we do when the heart completely stops. The main goal for cardiopulmonary resuscitation is to pump or imitate the pumping action of the blood. That's why we are squeezing and then letting go of their chest area, because we are trying to imitate the action of the heart. Okay. uh Pacemakers, there is a cardioversion where there's a delivery of a synchronized shock, and then defibrillation, this is an electrical shock to the heart to kind of like restore the normal cardiac conduction. And then implanted pacemaker are those patients that have, let's say there's a problem with their SA node, which is the normal pacemaker of the body. Then we can do like an implanted pacemaker. It could help with initiating those electrical impulse. Oh, okay. Therapeutic measures for peripheral vascular disease. So we did touch peripheral vascular disease a little bit when we're talking about those valves that is not working properly. So then what happens is that the blood flow, or I'm sorry, the blood or the fluid in the body is just pulling down because of the gravity. Um, it's not circulating properly in the body as it should be. So what we can do for those patients that have peripheral vascular disease is to make sure they do exercise, stress management, pain management, smoking cessation, and then elastic stockings. So there is a picture in the book as to um, how and when we would do these elastic stockings. In page 634, this one is talking about how we could um, put on those elastic stockings to our patients. And this will help with making sure that the fluid is not pulling in the lower extremities and it's actually um, going to flow normally to the body. We need to remove this though at least twice a day to check for like skin issues, okay, and to check for the circulation itself too. So with elastic stockings, you need to at least remove this at least twice a day, okay. Intermittent pneumatic compressions are those compressions that is intermittently doing it like on and off, on and off, on and off, kind of like squeezing and releasing their legs, the legs of the patient. And this is just mimicking that blood flow to the body. You know, it's going to go to the area and then it's going to be squeezed to other parts, okay. So intermittent pneumatic compression. Positioning, thermotherapy, protection, patient teaching, and dietary interventions, cardiovascular surgery, for preoperative nursing care. We can do activity restrictions to reduce the demands on the heart and then reduce the stress and anxiety. For post-operative nursing care, we are checking for the changes in the vital signs, breath sounds, urine output, mental alertness, and color, and then also assessing the urine amount, and then appearance and odor.